So our final speaker of this session is Tony Aldave, who's going to present a case, an interactive case, which you can respond through your phones on Crosslinking. Tony.
Thank you very much, and I encourage everybody to go to page 12 of the program. You can see the instructions as to how to, via your phone, log in and be able to respond to the question that I'll have during this presentation. I want to thank Dr. Patel, Dr. Lee, Dr. Dang for the invitation to speak, and thank all of you for being here so early this morning. I have an interesting case to present to you. By way of disclosure, I have no financial interests relevant to the case presentation. It's of a 58-year-old woman who presented with increasing topographic astigmatism in her right eye. She's been wearing glasses and contact lenses since she was a teenager, was diagnosed with pellucid versus keratoconus, and referred for corneal crosslinking. You see her corrected visual acuities 20/80, 20/20, a high degree of cylinder in the right eye. Tomography showed, again, a high astigmatism in the right eye, not so high in the left, with minimum central corneal thickness approximately 400 microns in each eye. Tomographic imaging of the right eye demonstrates this infratemporal steepening, as we see here. And in both eyes, the pachymetry map, we can see that there's not just central thinning, but there's actually global thinning, with these peripheral pachymetries only maybe high 400s or so in each eye. So she underwent epi-off crosslinking for progressive keratoconus in the right eye. 1 month after crosslinking was performed, she developed spontaneous microperforation of the cornea. 3 months later, developed a second microperforation of the right cornea, which, as you see, was managed with bandaged contact lens and aqueous suppression. Photograph here of the right eye demonstrating the temporal mid-periphery, the loci of the prior corneal perforations, and the slit beam showing that she had diffuse corneal thinning in that right eye. So the following year, the patient noted worsening of vision, now secondary to progressive myopia and astigmatism in the left eye, the untreated eye. Astigmatism increased from 0.8 to 4.7 diopters, although the corrected vision and refractive astigmatism remained relatively stable. So the question is for you this morning, what are you going to do for this patient who now has progressive steepening of the cornea in her left eye, having had the microperforation in the right eye? Epi-on crosslinking, number 1. Number 2, epi-off crosslinking. Or number 3, benign neglect. I'll let everybody vote. Okay, so we have a split decision. Most of you voting for epi-off crosslinking. It worked so well the first time, why not do it again? Some people voted for epi-on, and then benign neglect came in third. So let's see what we did. Well, the patient had epi-on crosslinking performed for keratoconus in the left eye. 8 days after crosslinking is performed, patient developed spontaneous perforation of the left cornea. So maybe we want to take that vote over again, might see a different distribution. Managed with sutures, amniotic membrane transplantation, and fibrin sealant. Now, her daughter also is a high myope. You see her, yes, it gets better. Her visions, you see 20/25 in each eye, high myopia. Tomography demonstrated low astigmatism in each eye. And like her mother, minimum pachymetry, about 400 microns in each eye. Tomographic imaging demonstrated in the right eye and the left eye some mild inferior paracentral steepening. But again, what was most prominent was on the pachymetry map, this thin central corneas and this global thinning. Again, here we see that the peripheral corneal thickness around 480 microns in each eye. So the question is, do these mother and daughter, they have keratoconus or do they have keratoglobus? So we looked at the corneal thickness in the central, paracentral, and peripheral region in both the Proband, our patient who developed the perforation, and in her daughter. And we see the values here, and we're comparing them to a cohort of patients with keratoconus, looking at the mean. And because their values were within 2 standard deviations of the mean for keratoconus at every point other than in the periphery of the Proband's right eye, we decided they more likely had keratoconus as opposed to keratoglobus. Now the question is, of course, since we saw the perforation in this, the mother, and we saw this global thinning in each eye. Is there's some inherited condition here that may differentiate it from a typical keratoconus. One thing that came to mind was brittle cornea syndrome. There's two genes that have been associated with that, the ZNF469, which is the gene most strongly associated to central corneal thickness in multiple genome-wide association studies. Homozygous mutations in this gene cause brittle cornea syndrome type 1. Heterozygous missense mutations are associated with a keratoconic phenotype like we saw in our patient and her daughter. PRDM5 also has been associated with brittle corneal syndrome, in this case homozygous deletions and nonsense mutations associated with brittle corneal syndrome type 2, but patients who are carriers of heterozygous deletions often manifest decreased corneal thickness. So we screen these genes in the mother, as we see here, the daughter, and in the unaffected father of the daughter. And we found these three variants in the ZNF469 gene, each present in the heterozygous state, that were not present in the unaffected father, and that were present in 1 in 1,000 or fewer individuals in the general population. Now, have these been associated with keratoconus before? In fact, the answer is yes. 2 of them have been reported before to be associated with keratoconus. If we look at the population prevalence of these 3 variants that were identified in the proband and her daughter, here we can see the population prevalence being, as I mentioned, 1 in 1,000 or less. However, the patient and her daughter are Ashkenazi Jewish, and we look at that subpopulation, we see that these are not as uncommon, with a population prevalence of being between 1.4 and 3.4% in the Ashkenazi Jewish population, leading to some question regarding the pathogenicity of these variants. So, question is, what are you going to learn from this talk? What are these potential risk factors that may differentiate this sort of a patient from your typical keratoconic patient in whom you're considering cross-linking, and thus may be an indication for doing genetic testing? Well, atypical clinical features of keratoconus, stable refraction during early adulthood, in contrast to the typical progression of keratoconus at this age. Topographic evidence of progressive steepening noted in the 6th decade of life, as we saw in our proband, resulting in a late diagnosis of keratoconus, and diffuse stromal thinning, in contrast to the thinning typically being localized to the area of ectasia in keratoconus. And what about Ashkenazi Jewish ethnicity? Is that a risk factor? You say, well, you just have one case. No, I actually have a second case. 22-year-old gentleman brought to my attention just about 6 weeks ago, diagnosed with keratoconus earlier this year. You see his refraction in each eye in March of 2018 and then June of this year. Central corneal thickness here was normal. Topography, he was steep in each eye, more so in the left than in the right. Topography showed the skewing of the radial axes in the right eye, infratemporal steepening in the left eye. He underwent epi-off cross-linking for progressive keratoconus in his left eye in July of this year. And 3 days after cross-linking performed, he'd have presented with superior multifocal infiltrates and a central corneal perforation, managed with glue and a contact lens. The cultures grew a few colonies of staph. Dr. Muniers was the doctor in this case. He gave me permission to share this case with you as well as these photographs. And in discussions with him, he says even though there's these infiltrates that are present, he felt strongly that these were sterile infiltrates, and that infection was not the cause of the perforation, that this was something else. So we just obtained the DNA from the patient, from his father, and from his mother. This is about 2 weeks ago. And what did we find? We found the same variant present in our proband who developed corneal perforation. Again, that variant that's present in less than 1 in 1,000 individuals in the general population, and less than 3% of those of Ashkenazi Jewish ancestry. So if you have a patient who fits this atypical profile and whom you think genetic testing might be useful or should be performed prior to doing cross-linking, where can you send your DNA sample? These are just 2 laboratories, CGC Genetics, which I believe is in Portugal, which offers a testing panel for brittle cornea syndromes, type 1 and 2, as well as Asper Bio, which is in Estonia, which also offers genetic testing of these genes. I want to thank you very much for your attention.